So there will be questions and I want you to answer, okay? Don't be shy. I'm gonna bring this closer so you can see. Okay, good. Yeah, so theory in physiology, that's for first year, second years, okay? You just start, learn your theory, learn how it works, the ECG, because then you will understand what does it mean AVF. You know how everything is negative, so you have the center of the heart. I don't know if you did it already.
We started.
Okay. So first you go to your theory, Najib, if you know Najib, osmosis and stuff like that, and then you move on to pathology and practice. So you practice. You watch real life ECGs and stuff. This website is very nice. You put the pathology. It has 3-4 examples explaining each what you should see. Our German books are very good. This one and this one, they have all the ECG samples. This one has everything from beginning to end. Theory, examples, practice paper. Same with this one. Theory, examples, practice paper. Okay, so that's why it's called the only ECG book you'll ever need, because it has everything inside.
I use that book and I can recommend it.
The English one, yeah, it's very good. And then there's some YouTube videos of Charlotte. She did 3 months ago. I watched it and it's very nice. Like she goes through this procedure, the steps, what you have to do, and she goes in more detail. I didn't have time to go in all the details, so I'm also don't even have time to go through this. I'll just skip slides, okay? Because it's impossible to do 1 hour ECG. But I will focus more on the pathology one, okay? Because it's interpretation, not so I'm sorry for the second years and first years. One question for you. Which plant is the healthy one and which plant is the sick one? Left or right? Left is the
healthy one.
How do you know?
Because
how do you know?
It's kind of vibing out there, man. It's alive.
So the answer I was looking for is you saw it so many times, right? So you saw it so many times that it's instant. Just by looking at it, you get it. So ECG is something like the same thing. Once you look at it, you will be able to get it, but you need practice, right? So fake it till you make it. I don't know if you know this sentence. Fake it till you make it. So you are allowed to have some cheat sheets, right? Like the one I gave you. So you can have the information. You don't have to memorize it. You can use it. No one is examining you. It's not an exam, right? So you can use these cheat sheets. You can buy like these rulers that you can estimate the heart rate and stuff on Amazon. Yeah, so you can basically cheat your way until you finally understand what the hell is bradycardia, what the hell is tachycardia, just by looking at it. But in the beginning, you can use a cheat sheet. You have always in your scrubs the ruler. You take it out. Okay, so it's much faster. Yeah, so these are the steps. Basically, this is the process. And if you do it a lot of time, it's like doctor's ABC. If you do it enough times, it comes like a reflex. The same thing with ECG. If you do it enough times, then you know how to start and how to continue. And these are the steps of what you should be doing every time when you see an ECG. Okay? So let's start by doing the first thing. So what is the first thing that you look on an ECG paper?
Lead 1.
What do you say?
Lead 1.
Lead 1.
AVF.
AVF.
Frequency.
Frequency.
P-wave.
P-wave.
Or I guess according.
Yeah, so basically everything that is not ECG paper, that is not an ECG tracing, okay? So everything above. So the calibration, this is a German paper, so it's 50. But all the theory, you know, is 25, okay? You see the height, the volt, you see the patient name, is it the correct patient? You see the time. There is a difference between electric time and actual paper time. So electronic is the one that the nurse is gonna type in. So when you look at it on the computer, maybe the time is different. Here is 1 hour difference. This is the actual ECG when it was taken, but this is when it was logged in on the system. So also, there is a lot of ECGs for one patient, right? And they just put them in the box. So maybe they get twisted around. So a patient who is getting worse, like the next ECG is worse than the first one, and the third one is worse than the second. If you put them on the other way, you'll say, this guy was worse, but now he's getting better. So if you read it on the opposite side. So everything you do first is look not on the ECG tracing, everything around it, okay? Make sure that what you're looking is the correct time, correct patient, okay? Yeah, and you might think that this doesn't happen, but I actually took blood from the wrong patient, you know, like it happens. So always do it. It might look like idiot thing to do, but like check everything. Yeah, so in Germany we have 50, but the international guidelines is like 25, what they use in England, stuff like that. So what does it mean 50 in comparison to 25? On my limits, on my cutoff points. If I say QRS is less than 3 small squares when it's 25. QRS is less than 3 small squares. So how many small squares will this one be?
6.
Yeah, exactly. So doubling. 6. Okay, so it's basically you double the you double the limits, okay, on the width. But the height, the millivolt, is the same. Okay, so if you go to Germany, you see if it's 25 or 50. If it's 50, you know that your limits are doubled. That's it. So no need to calculate, no need to make milliseconds or whatever. Just use small squares, big squares, and just double it, okay? So the way I learned ECG is like small squares and big squares. And then you know if it's 50, then you double it. If it's normal, you just use the normal values. So learn it by 25, because that's all the YouTube videos, everything is 25. And then if you work in Germany like you girls want to do, you just know that double the small squares. So what is the first thing we're looking on the tracing?
Frequency?
Regular, irregular.
Yeah.
The action.
Sinus frequency?
Okay, so you said the rate,
Yeah.
the frequency, you say rate. What is the rate? You don't say frequency. Who said frequency? Someone said frequency.
Yeah, me, sorry.
Yeah, when you say frequency, you don't say frequency, you say rate.
Okay.
There is like a name for it. Okay, and you said regular, irregular, or you say rhythm. Okay, good. So the first thing we look is the rhythm. Okay, and how do you calculate the rhythm? It can be regular or irregular. So
The distance between two ionic tables.
yeah, good. So which one is regular and which one is irregular here?
The left is regular.
Yeah, good. So what you do, you put a paper and you put the two RR waves, and then you move the paper, and all of them should be exactly the same, right? Not even one small single square difference? Exactly the same?
No, there are even physiological differences. Right?
Okay, so basically I use two small squares. Two small squares, okay. So in the 50 it can be like 4 squares. Yeah, so there is this trick that you can use, but when you have this ruler I showed you with all the values on it, it's already pre-calculated. Another trick is you take a piece of paper, you put mark RR on it, and then you move the paper along, and you try to see if it changes. And 1 to 2 squares is acceptable, okay? Small squares. So this is irregular. You see that the differences from here to here is not the same as here to here. So why are we doing this first? The rhythm and not the rate?
Because everything is the first thing you see, like effect.
Okay, the calculation basically. You know, you have regular, irregular, and you have different calculation of the rate. If it's regular, you can use the calculation like 300 divided by large squares or 1500 divided by small. If you're using the double paper, then you double the number. Yes, like because it's double the paper. But if it's irregular, you cannot use any calculations. You have to actually measure it. Okay, so you take a 6 times 10. Some people use 6 seconds times 10 or 10 seconds times 6. So you choose. It's 6 times 10. Okay. I can send it to you the presentation if you want.
Why does Germany have this double rate system?
What?
Why does Germany have this double rate system?
Why does?
Germany have this double rate system.
Because we don't care for the economy of the paper, right? So you have one A4 paper, 1, 2, 3 AVR, AVR, AVL, AVF, one A4 paper, and then you have another A4 paper, V1 until V6. So you have 2 A4 papers. But if you use 25, you can cram everything into one A4 paper. So it's easier to handle. But we want to have accuracy rather than saving paper.
Diagnosis to have 50 millimeters.
Yeah, because it's more accurate. You see the differences. So if you have a small Q wave, now it's double the size, so you can see it. But if it's too fast, you can miss it. Yeah, so what is the rate in this one? So first thing you do, rhythm. Is it regular or irregular?
Wait, what is this calibration? German or Czech?
This is 25.
Okay.
So
75.
is it regular or irregular? It's regular or irregular? Regular, okay, so I'm helping you now. I'm giving you the numbers there. 23 small squares or 4.5 big squares. So what is the heart rate? Yeah, it's regular, okay, good. But now I'm giving you the distance, so what is the heart rate?
Like 85?
Okay, so it's 65.
Yeah, it was something
Okay.
to rule from the 300.
What about this one? I'm helping you, right? So this strip is 50 big squares, and you know that 5 large is 1 second.
Yeah, but this is irregular.
Irregular, so you cannot use calculation, you cannot use math. If it's irregular, forget your math, you have to measure it yourself. So I'm helping you here, like 50 big squares, and that's like time conversion.
I didn't choose math for that.
So
multiplied by 6. All the
Depends. What are you using? All of them. All of them multiply by 6. Okay.
All of them are 10 seconds.
Yes. Add a 0. Add a 0. So 50, 10 seconds. Multiply by 6. So how many R spikes do you see?
300 beats per minute.
Yeah, 17 R waves times 6.
17.
Okay, good. So you're getting it. You understand now. First, we do the rhythm. If it's regular, go to mathematics. If it's irregular, start counting. Okay? Is this clear?
I don't understand how do you calculate a regular?
This one,
Yeah.
the whole paper is 50 big squares, right? Which means if 5 large squares is 1 second, then 50 is 10.
Yeah.
So this is 10 seconds.
10.
So per minute, how many seconds in a minute?
60.
So
6 times.
this is 10 seconds times 6. So there are 17 R waves, R spikes. So that's how you do it. Good. So we said irregular rhythm. It means that the RR interval are not the same all the time. Yes. But then we have regularly irregular and irregularly irregular. Does anyone know what does this mean?
Yeah, the regular there is a irregularity.
There's a pattern in the
there is
irregularity.
something repeating which is not normal.
Okay, so it's a pattern. But both of them have the RR intervals are not the same.
Yes.
Yeah.
Okay, good. Yeah, so we did the steps. First one, check everything not on the ECG, calibration, the rhythm. Then we know which calculation to use. So then we have the rate. Okay, and then the next step is axis. Do you know the limb leads? What are the limb leads? Which ones are the limb leads?
1, 2, 3.
So 3.
1,
Good.
3.
That's it. There's no other limb leads.
No. Is it?
The 1, 2, 3, AVL.
Yeah, good. So everything that is not VVV1, that's limbs. And where do they go? Where do these things go on this graph?
Okay, so
What is 0?
AVO.
AVL.
So it should be 1,
It's
2,
1.
This is 1?
3.
No, AVL is 90.
You know this? Okay, so when you say AV, okay, it means that all the leads are negative electrode.
That's 2.
So you start from the center. Then you say AVF, it means from the center of the heart going downwards. If you say AVF, from the center of the heart going to the AVL, to the left arm, okay? So imagine like a guy standing like this and like this. Okay, so AV means from the center, and then L is that way, R is that way, and F is down. So if you imagine that here is the face, here are the legs, and this is the hands, this is the left, the right, and the foot. Okay, so this one is which lead? One.
No?
The normal axis is towards the right, the number 2, right? That's why we always do number 2.
Yeah.
So from anatomy, the heart is on the left and a bit downwards.
Okay.
So on the left and a bit downwards, that's number 2. That's why you look number 2. It's the most physiological.
Okay.
So this is number 1, and this is number the one that is left. Good. So that's your axis, and yeah, just revise it a bit, so you know your things. Good. And then you know what is an axis estimation versus calculation. Like the heart axis, you can estimate it, and then you can actually calculate it in second year. Who is from first faculty? No one?
Like you can estimate it by, for example, if it's on lead 1, it's 0 degrees. If it's on lead 2, it's minus 30. Lead 3, minus 60.
What is only on lead 1?
Sorry?
What do you mean it's only on lead 1?
No, the degree on the estimate.
I think the estimation
Deflection,
is
yeah.
you look at the positivity and negativity
Of?
depends like leads for example QRS.
QRS, okay, R. Okay, back, everyone here. Okay, in our faculty, in our physiology exam, we have to take lead number 1, and then AVF. So you make like a right angle, 90 degrees, and then you count exactly what you said, and you count the squares, how much is going to the right, and how much is going to the foot, and then you make the vector, and you find the angle, okay? That's calculation. But when you're in the acute clinical setting, you don't have time to calculate it, so you estimate it. Okay, so how do you think you could estimate the axis? Very fast.
You mean like left laterally? If you like
Okay, so this is a calculation, right? This is a calculation, what you're saying. So you take 1 and AVF, so horizontal and vertical down, how much right and how much down going. Then you make the vector, and for example, this is 15, so 15 towards the right, right? And then if you take the AVF, then you find towards the down, and you make the vector. That's calculating. But how could you estimate it?
AVR, I think. one of those leads?
Positive, negative.
Yeah. You see what
Deviation.
one-
The highest wave in the QRS complex, we follow it and we check impulse and we check 1 and 3. No, AVF doesn't
Yeah.
exist.
If they look at each other, they're
Yes.
right. If they look
If they're
apart.
both up, it's normal axis.
Yeah.
For which lead?
Lead
1 and
lead
3.
Yeah.
1 and 3.
Yes,
What about number 2?
we do
1
1
and
and 3.
IVF. No?
Okay, so basically how you estimate it is that,
Also electric one.
What do you
like here, can you estimate it here? Like, can you estimate the axis on this one? How many degrees do you estimate it? Tell me a number. Like, which number are you estimating?
I mean,
Between
Instead of calculating exactly the number, you just estimate. Oh, I think it's 40. I think it's 40, between 40 and 50.
30 and 60.
Why do you think it's, so you think it's somewhere here, 30 and 60, somewhere
Yes.
here?
No, sorry, 90 and
I think
60,
it's
my
above
bad.
90 and
60.
60.
90 and 60.
So you think about 60?
Yeah,
Can you
above,
repeat how?
above 60. Because
By
the
not
lead-
calculating the squares and doing all this
Okay.
process, just by looking at it, you say, I think it's here, I think it's there.
Definitely.
Just by looking at the ECG.
90 to
Between 90
60.
and 60.
Yeah,
Between
60 and 90.
Here?
Mm.
Okay, why? How did you
I
find
was
it?
just looking at like if I looked at number 2, lead 2,
Mhm.
and it really has like a high peak, so I go more
Yeah.
positive. And the same for the other leads. So I looked at 2 and yeah.
Okay, good. So basically, so the highest R wave is number 2, okay? Then you see that we're going this way. So we're very close to 60, okay? Then we have AVF and 1. So 1 is very small and AVF is basically as big as number 2, a bit smaller. So I will deviate towards AVF. And number 3, it's smaller than AVF. So I would say that I'm higher than 60, like I'm that way, 65, you know? So you estimate it by the R waves. I don't know if it makes any sense. You understand it? Do you get it?
No.
So the biggest R wave, it means I am targeting that lead, and then you try to compare the neighboring leads to see which one is bigger. So you do like a small deviation. So here the highest one is number 2, so I'm going towards number 2, and then I have to compare number 1 and AVF. So the R wave of number AVF and number 1. And you see that AVF is bigger than number 1, so I'm going towards AVF, not towards 1. So it will not be 50, 40, 30, it will be like 70, 80. So I did it here for you, I calculated it for you, and the angle is 68.2. So your calculation is it takes time, but you can estimate by using this, like find the biggest R and then compare the neighboring axis. So that's a fast way to find the axis. You don't have time to calculate it, count the squares, no time for this. Just look, highest R, which one is bigger, especially when you have the bundle branches block, the hemi blocks. You just look at the axis, you're like, okay, deviation, and then you keep going. Okay, so you can do it in 1 second. Yeah, okay, skip this one. Axis deviations, okay, we found the axis. Okay, what does the P wave represent? P waves?
Depolarization.
Okay, which atria, left or right?
Right.
Only the right. So where is the left depolarization? Left atrial depolarization is which wave? I know I'm confusing you. Okay, so P wave is depolarization of what? SA node. So the SA node has so much muscle that it will be visible on the skin. You cannot see SA node depolarization because it's too small. You need muscle, like left ventricle, a lot of muscle, huge QRS, right? So it's not SA node. So what is P wave?
The right atrium depolarization first, and then the spread to the left atrium.
So both.
Yes.
Okay, good. It's both. So P wave is both atrium. Okay, don't say right or left. It's both of them. The thing is that at the point they overlap. So then this is a vector, right? So it's electrical activity, and when they overlap, it's higher. Okay, so it doesn't follow exactly the wave. Here they overlap, so it's summation. So it makes a P wave. First is the right atrium, then it's the left atrium. Okay, yes. Then you get your P wave. So how will the P wave look in pulmonary disease, and how will the P wave look in mitral stenosis, and why?
In mitral stenosis, it looks like an M somehow, the P wave.
It's called BFID.
Yes.
Okay, and what is the name of this P you said? There's a name for it. It's called P. P ventrale.
Yes.
Okay, P ventrale. And for pulmonary disease?
P pulmonale.
P pulmonale, which means?
it's not, how to say it, like the M is not with an angle, but it's more curved.
Okay, no. The pulmonale one, it means that there's a problem with the lungs. So then the right atrium is hypertrophied. So when the right atrium is hypertrophied, it always expands towards the right. So the red one expands towards the right. So this one expanded towards the right. So it comes like this, and we talk about overlapping is summation, right? So they overlap a lot, so it's super high. It makes this peak one. Okay? Here, the mitral stenosis is making the left atrium hypertrophy. So the left one goes towards the right. There is no overlapping, but it's prolongation. So you make this one here, the B-fit one. Okay? So P mitrale and P pulmonale. Okay? That's the P wave. Can the P wave be absent, and if yes, when?
Flutter fibrillation.
Where?
Flutter fibrillation.
Fabry fibrillation. Okay. What else?
It could be either hidden in QRS complex or followed by the
Pacemaker.
Blocks.
after QRS.
In blocks, you have.
At some point, you.
It could be. Yes. What else?
Wait, wouldn't there be a presence of the P wave because of a block? An AV block usually has P wave.
It could be hidden inside the T,
Yes.
but we will do it after. What about asystole? What about VFib? How does VFib look like? What about torsans de Boyns? How does it look like? Do you know these things?
Yeah.
Exactly. So, yeah, there's a lot of ways that it cannot be present. What about this one? What is this one? Do you know what is it? What? Yeah, it's flutter. Okay, good. So, we don't call them P waves. Okay. You might say, oh, I see P waves here. But we don't call them P waves. What we call them is capital F, flutter. Why capital F? Because they have a nice shape. So they get the capital one. And the fibrillatory ones that they don't have a nice shape, we call them small f. Okay, so capital F is the one that they are presentable. It's like capital, big. And small f is like very tiny, like fibrillatory waves. Okay. You can name this sawtooth because it looks like the teeth of the saw. You know, if you look here, like exactly. So that's flutter. And that's your fibrillation, atrial fibrillation. What is this one? We said it's a flutter. Good. It's a 3-to-1 ratio, but it can also be like random or different ratio. You have here different varieties. You have this in your sheet, how to do narrow complex tachycardia. So QRS is narrow, it's irregular rhythm, and there is F waves, capital F waves, right? It's not the small f, it's a capital F. So then you end up in the flutter, okay? So you can follow this one and find what is your diagnosis. And these are intervals. We call them regularly irregular, okay? Because there's a pattern there. Every 2, there is 1. What is this one? You can use your things in your sheet I gave you. You can use this one to find the diagnosis. Is it regular or irregular?
Irregular.
Okay. And then, what is the next question on the diagram?
If no P or fibrillatory waves present or atrial, regular atrial activity.
So, what do you think this one is? Use this
I
one.
would say like no P present.
So, what is your diagnosis?
Atrial fibrillation.
Yeah, that's atrial fibrillation, okay? So that's your atrial fibrillation. Because we go here, irregular, F waves, these are the F waves, and then atrial fibrillation, okay? Good. What is this one? You can use the same sheet, reference sheet. Okay, this is a tricky one. We'll start from you. Do you have an answer?
Tachycardia.
Which one?
Sinus.
Sinus tachycardia? Sinus tachycardia. And you? Sinus tachycardia? Sinus tachycardia? Did you follow this one? You have an answer? Like you follow the steps? Follow the steps. So sinus, and what do you say?
I say sinus tachy.
Sinus tachy, and what do you say? Atrial flutter, okay, and what do you say? Sinus tachy, and what do you say? Okay, so basically this is the biggest mistake of students. Everyone says sinus tachycardia, right? But actually it's AVNRT. Whenever you see a QRS, there should always be a T wave. always. So this one is not a P, it's a T wave.
Which one?
So you come to regular, there is no P, so it means it's AVNRT. You understand? So the AVNRT and the sinus tachycardia is so similar that people confuse them. But if you see something going after the QRS, always is a T. Don't say that that's a P because it's before QRS. Don't go from QRS backwards, go from QRS forwards, okay? And that's your T. So a lot of students go sinus P because they think that it's a P. But if that was a P, then where the hell is your T wave? Okay, remember, this is like, yeah, everyone make the mistake, but all the students make it. Even I did it when I was in school. So now you remember, when you see a QRS, go after, that's a T, and then you try to find the P.
Yeah, but it's tricky because the first one is
I know it's a tricky because that's actually from my lecture in uni. That's what the professor used. Yeah, so that's another important thing. What about this one? What's the problem here? Can you see? Can you come closer? What year are you in? Second year. Okay. I hope you understand. So what is the problem here? Okay. So what is the next step I have to do now? I found an inverted P wave. So what is the next step? What am I looking for? I see an inverted P. I have to check this one.
You have to check if the leads are put correctly.
But the QRS and the T are normal, so they will everything will be inverted, right? So the next step is PR interval. What does PR interval represent?
Atrial.
PR interval. So how do you call that one? Exactly what you say is correct, but the AV node delay, good. So if you start from here and depolarize upwards, you will have an inverted P, right? Good. And the same with here. If you start here and depolarize upwards, you have an inverted P, because instead of SA node downwards, you go from downwards upwards. So you have an inverted P. But the difference is that this one, the electricity is already here. So the PR interval is shorter because the electricity is already there and it's going to go to the ventricles. While here, the electricity has to travel all the way to AV node, then travel to ventricles. So this one is the PR interval is too long, okay? So if you see an inverted P wave, you check the PR interval. If it's too long, it means it came from the atria. If it's too short, it came from the AV node, okay? So that's another thing. When you see inverted Ps, check your PR interval to know if it's from AV node or somewhere else in the atria. Yeah, so that's another thing. We finished with the P wave morphology. Yeah, so we did these steps. We're halfway there. Going on to the next one, PR interval. You said it represents AVN delay, and it starts from the beginning of P until the beginning of QRS, and it should be 3 to 5 small squares. And then you just double it for if you go to Germany. So what is this one? When we think about PR intervals, okay, we're in the chapter of PR intervals. So I'm helping you here. It's bradycardia, okay. Look at the PR interval. 3 to 5 squares, right? 3 to 5. So how many squares do you see here? 8 squares. You have constantly 8 squares as PR interval instead of 3 to 5. So what does this mean? AV block, which degree?
Okay, type 1.
It's first degree AV block, okay? Why? Because, okay, it's regular, and then it's just the prolongation of PR. If everything is normal, just PR is more than 5, because we know it's 3 to 5. For example, here it was always 8. Then it's first degree AV block, okay? That's it. First degree, it just means prolonged PR, done, okay? First degree means that the AV node is slow. It's not sick, it's just slow, okay? So first degree. If it's too slow, the P wave might end up inside the T, okay? So keep in mind that if it's too prolonged, the PR interval, the T wave, it's repolarizing, but the SA node doesn't know that, oh my God, I have to wait for T wave to stop. It just depolarizes. So you have your P wave. So the SA node will not wait for the T wave to finish, then it will give you the P. It's giving the P while the T wave is happening. So here you see that the SA node depolarized, but the previous one, the AV node was too slow, so the QRS came slower, the T wave came slower, but the SA node doesn't know that. The SA node thinks that from this time until this time, it was more than enough to finish the whole QRS T, okay? So be careful if sometimes you see this one, the P wave can be at the end of T, if the PR interval is too prolonged, okay? So first degree, if you don't see P waves, try to find them inside the T. That's your first degree.
in healthy individuals?
First degree AV block,
Yes.
it's not healthy.
It's not.
No, 3 to 5 is the healthy one. So it means that the AV node is slow, okay? So that's our pathologies. What is this one? Related to the PR interval, because we're doing PR interval now.
It's very hard to see now. It's a look.
Second block. Second degree block.
Which one?
No wait.
PR is getting bigger and bigger and bigger, then drops, right? Drop beats. Which one has bigger and bigger and bigger, then drops?
That's second.
Second degree, which Mobitz? Mobitz 1, good. So Mobitz 1, it's the one that it's small and becomes bigger, bigger, bigger and drops. So it's slower and slower and slower, then drops, but when it comes back, it's again small, okay? So Mobitz 1, it's like short, longer, longer drops. Short, longer, longer drops, okay? That's Mobitz 1. What is this one?
The 2P waves.
Mobits 2.
Yeah.
Second.
So the red one is a drop beat, and the PR interval is the same, okay? But is it like normal or is it prolonged?
It's not.
It's prolonged. Same drop, same drop, yeah? So this is the Mobitz 2. When you have same drop, so it's like same and slow, same and slow, same and slow, so it's more than 5 small squares, then drop, and then again same and slow, so it's like beep, 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 nothing, beep, 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 nothing. While the Mobitz type 1 is longer and drops. Good. What is the next one? We're doing PR intervals, I'm helping you.
Third block.
Third degree, why?
Because the P's and the QS complex are regular between them but completely disconnected.
So that is Mobitz 2 as well. So basically, you can estimate, you can see that the P's are regular, but it's what we said before. It's inside the T wave, you know, like, and then you have drop beats as well. So they are linked. It's 2 to 1, okay. So they are linked. The P waves are not buried inside QRS, so it's not the third degree. And then you have the PR interval. That's Mobitz 2. Yeah, that was a tricky question. Just to make sure that you look the whole line, okay. Try to find all the P's. And yeah, so what is this one? Now you're not confident in your answers anymore. Okay, so
Third degree.
yeah, this one is the third degree. So you go QRS, QRS, QRS. The blue ones are QRS, and the red one is the P's. The yellow one is where I am guessing is a P, but it's hidden because something else is going on, like a T wave or a QRS. So everything that is yellow, for example, here is a T wave, and it's inside the P wave. You know, it's hidden. Here is hidden. Here is hidden. So you see that it's regularly. They have their own pace. The atria, 60, and then QRS, the ventricles, they have their own rate, 27. Okay? That's basically the theory. You have a PP that is regular, let's say, and then RR that is regular, but they are dissociated. Atrial rhythm by itself and ventricle by itself. There is also PR shortening, but we don't have time to talk about it, but it's an important disease, the Wolff-Parkinson-White syndrome. Just make sure that it's 2 ECGs. There is the Wolff-Parkinson-White rhythm and the Wolff-Parkinson-White tachycardia. Okay, it's 2 different ECGs. When you study it, don't confuse it. Know that Wolff-Parkinson-White means 2 ECGs, not just 1. Okay? You can watch the lecture of Charlotte, it's explaining it as well. So we finished half of the ECG or more than half, and then Q wave. Q wave, what does it represent, the Q wave?
Start of ventricular. No.
We're talking about electricity, right? So no contractions. It's depolarization, repolarization, only electricity.
Okay.
No, we're in the ventricle.
What? Lateral depolarization? Ventricular?
Yeah, ventricular.
So what is the R wave?
There are different. S is one of them is septal, and then.
Which one is septal?
The Q.
Exactly, Q. Okay. Good. And does it depolarize the septum from left to right or right to left?
Left to right.
Towards the
No, right to the
From the right to the left.
towards the right to the left.
Who said left to right? Correct. Good. So
Trying to remember
you
the
have
picture.
the left, you have the left bundle branch, like, and then it splits into a lot of fascicles. So the left one will give you anterior, posterior, and also septa. So the septum is depolarizing from left to right. Okay. So the Q wave is negative because lead one is looking at this, going away from it. You know that the leads, they like the chaos, right? They are very happy and positive when they see depolarization coming towards them, and they're also happy when they see repolarization going away from them. Okay? They want to have no repolarizations and depolarizations. They love chaos. That's how to remember the positivity. So here you have depolarization going away, so lead one is not happy. Okay? Because the depolarization that it likes, the chaos, it's going away, so it's becoming sad. Okay, that's an easy way to memorize it. When you have dead muscle, then this acts like a window, so you can see better what's going on inside. So when you have here MI, you can see the Q wave better, so it's more negative. Okay? The septum didn't change, nothing changed with the septal depolarization, is that this muscle is dead, so now you see it more negative. Okay? So if you see a very pathological Q, you should think that my septum is fine, but something else in the ventricles is going bad. Okay? When you have a left bundle branch block, how will the septum depolarize? And how will the Q wave look like?
It goes around. Yeah. What was that called?
So if I block it here, then how will this? It will depolarize from right to left. We're gonna go through it. I'm asking, yeah, it's inverted. So they will go for, if you have left bundle branch block, then septal depolarization is from the right towards the left. Okay, so the Q wave is inverted. Okay, yes? So septum depolarizes from left to right unless you have the left block, it goes the other way around. Okay? Okay, keep this in mind. We're gonna do blocks later if we have time. Yeah, so that's your Q wave. What is this one? This is supposed to be continuation of the line. Okay, and can you use the tachycardia inside, the term tachycardia inside your definition?
Yeah.
Okay, good. So basically, this is ventricular fibrillation, polymorphic, sustained, broad coalescent ventricular tachycardia. That's the full name. When you go to your theory, you can classify the ventricular tachycardias into polymorphic and monomorphic. Yes, and polymorphic basically means that they have a lot of shapes, different shapes. Monomorphic means it's the same repeating pattern. Sustained means that it doesn't go back to normal by itself. So if it doesn't go back to normal by itself, then you need to defibrillate it. Okay? If it's unsustained, it means that after a few beats, it's gonna recover by itself. If it's sustained, it means that it will not recover by itself. You need to fix it. Okay? That's a defibrillation. So if you see this one, you know that it's a defibrillation. Do you know what is R on T? R on T?
Like ventricular defibrillation, refibrillation happening around the same time.
Yes. So when you have a T wave, okay, a T wave is a repolarization of the ventricles. And there should be a nice flow of repolarization. When you try to do a defibrillation, so an R wave, during the repolarization, then half of it will not be affected and half of it will be affected. So then you are creating all these re-entries in the ventricles. And then you get VFib. So that's why we say we have to synchronize the defibrillation. When you say you have to be in sync, you put it there and you wait for the machine to read the ECG, then it will defibrillate. So that's why it's not like, okay, defibrillate. Psst, you don't do this one, like the movies. You put it there and you wait for the ECG to synchronize with the T wave, and then it will defibrillate, okay? If you don't synchronize it, then you may end up doing a tachycardia into a VFib, okay? So yeah, an important thing when you defibrillate. What is this one? So the previous one was polymorphic, and this one is monomorphic. Good. Monomorphic and sustained. This is sustained because it keeps going and it's not coming back to normal. Okay, that's your definitions. So monomorphic, polymorphic. Monomorphic is one shape, polymorphic is from this part onward, right? So this one onward is like different shapes. Different shapes. That's torsade points. It means you have the points and it's doing torsion around. Big, small, big, small. Okay? So that's polymorphic and monomorphics. What does it mean, narrow QRS and wide QRS? So how many small squares do you have to be bigger than that to have a wide QRS?
Normal QRS is 0.12.
Small squares. Tell me small squares.
Less than 3.
Yes, less than 3. Good. So I'm using squares because that's easier to memorize. Just memorize the squares, okay? That's it. Yeah. And if you have a wide QRS, majority will be ventricular, but some of them can be supraventricular. It's like rare. So every time you have a wide QRS, you think that it's ventricular tachycardia until proven otherwise, okay? Because it's so rare to have supraventricular with wide that you assume the most common, okay? And then the narrow QRS is supraventriculars. For narrow QRS tachycardias, I gave you the scheme, okay, that you can use. Good. So we said about sustained. Unsustained means that you are normal, then you have tachycardia, and then you have normal again, okay? So that one, we should find the treatment and the cause and treat it. But if it's sustained, like ventricular fibrillation, it will never go back by itself. You need to defibrillate it, okay? So sustained ones, you need to make them come back. Unsustained, they will come back, but you have time to fix it, okay? Yeah, shockable and non-shockable rhythms, revision. Which are the shockable? Bifib. That's it. No rhythm at all, it's non-shockable. You should not do it.
Okay.
Ventricular fibrillation and post-ventricular tachycardia are shockable, and
Pulses,
PA
electrical activity.
is
Good.
non-shockable.
Yeah, you're right. So this is what you said. So shockable is ventricular fibrillation and pulseless with a tachy, okay? And non-shockable, that you don't shock it, is asystole and pulseless electrical activity, okay? Good. Moving on, the next one, R wave progression. Have you heard this term before? What is an R wave progression? No one? Okay, so basically, you look at the V1 to V6, the chest leads, and how they move is like the R becomes more positive the way it's going towards V6, and the Q becomes less negative, okay? So this is the R wave progression, okay? And the 50-50 should be at V3 or V4. It should be somewhere here, V3, V4, usually V3. That's your 50-50, so it's 50% positive, 50% negative, okay? Here the 50-50 is in V2, yeah? So it's called an early progression. And here the 50-50 is in V5, so this is a late progression, okay? These are the pathologies that you should think about it when you have R wave progression pathologies, but you should look at the V1 to V6 and try to find 50-50 in V3 or V4, okay? So that's another thing we look about. Just a little note, where is the left side, here or here? Do you know how to look at the CT images, MRI images?
Yes.
So basically, when you put them inside, the patient looks like this, his legs looks towards you. So when the image comes, like this is the left side of the patient. Okay, you always look from the legs upwards. Good. Then, so what is this one? Mine, this is the double rate. So QRS should be 6 small squares.
Bradycardia, so I can say.
Okay.
Right, due to the V2.
ST depression or inverted T wave.
You said right. Okay, keep that thought. Okay, we're gonna do it later. Okay, let's go to the theory first. So bundle branch blocks. How many bundles we have and how many fascicles we have? Like anatomy of the bundle of his, and later on. Two bundles, left and right, and then.
Then left one divides into two fascicles.
Yeah, good. So bundle branch blocks. You know bundle branch blocks? How many bundles and how many fascicles? We've already said it already. You have right and left. The left one has anterior, posterior fascicle, and also septal. Yeah, that's why it's coming from the left to the right, the depolarization of the septum, the Q wave. This is an easier scheme to do when you think about it, when you study it. So you have right, left, and posterior, anterior fascicles. When you have problem with the QRS, also the T wave changes, right? Because when you change the ventricle depolarization, you also change the repolarization. They are linked, right? So when you have QRS problem, you have T wave as well. Okay, so it will be a wide QRS problem. You have T wave problems, but for the axis, these are called hemiblocks. When you break the fascicles here, the small blocks, the fascicles, posterior, anterior, you call them hemiblocks. The hemiblocks do have axis deviation, okay? But the bundle branch blocks, they don't have axis deviations, okay? They are not in the criteria. But the only one that has probability to have axis deviation is the left bundle branch block, okay? So let's do an exercise now. Deviations. We have there 4 questions. Right bundle branch block, left bundle branch block, left anterior, left posterior. What is the axis deviation for each? What do you think? How will the axis deviation be in right bundle branch block?
Towards the left.
Right.
Okay, we said we don't care. We said we don't care. It's all in the criteria. Okay, we don't care for this one. So it's normal. Right bundle branch block, it's normal. Why? Because the right ventricle will depolarize late, but it's so small that it's not enough to change the axis. Okay, we're talking about muscles depolarizing. Okay, so left bundle branch block.
Q wave will be positive.
Yes, Q wave inversion in the left bundle branch block, and what else? On the axis, talking about the axis here. How will the axis be?
No, depends.
Exactly, it's all in the criteria, but the left ventricle is so big that it may cause which axis deviation, left or right?
Right.
Okay, so think about it. Okay, visualization. You have the AV node, then you have left and right. Okay, so electricity goes from AVN to left and right ventricles. But if I block the left one, electricity is going to go to the right, and then from right to left. So the axis, instead of being like this, it's this way. So is it the axis deviation is
Towards the left.
towards the left. Okay, so instead of being like this, it's like this. The angle of this direction is going that direction. Okay, good. And what about the anterior fascicle? Okay, so I'll tell you the answers. I'll help you. We will skip some time. So basically, it's like this. This is septum, right? So the right ventricle is here. So when the left anterior is broken, the electricity goes towards away from the right ventricle. So it goes towards the left, right? So this is the left side. This is the right heart. You remember this one? It goes towards the left side. So this is the anterior fascicle makes a left axis deviation, and then the posterior one is making a right axis deviation. Okay, because this is the right ventricle here, so it's going towards. Normally the bundle of his will go down. The vector will go downwards and then down, but when you have a left block, this is the axis normally, so it's going like this. But when I go through this way, then the axis is like this. So that's a left axis deviation, right? Instead of going this way, I'm going that way. So that's instead of going like this way, I'm going this way. So the axis is left. So when you have a left bundle branch block, you may have left axis deviation, okay? Because the left ventricle is too big and it's going to affect the axis. But when you go the other way around, the right ventricle is too small, so you don't have so much axis deviation, okay? Do you know William Marrow? Like how they look like, William Marrow, mnemonic? So basically this means that the left bundle branch block is going to have V1 like a W and V6 like an M, and the right bundle branch we have V1 like an M and V6 like a W, okay? But when we describe something, we only care for the M. Okay, so bundle branch blocks, only the M, you don't care of the W. Don't forget about the W, okay? So when you have a right bundle branch, you focus on V1. When you have a left, you focus on V6, okay? Why? Because the M goes always with T wave inversion, okay? Everything else is normal, but your M has T wave inversion. Another thing, the left one is making a little jump, like you can see here, little jump. It doesn't go on the other side of the baseline. But the right bundle branch block, when you go to the M, you see that it changes from the baseline. Every time you change from the baseline, you get an extra letter. So this is RQR, because RQR. But the left bundle branch is just notched. These are notches, just a small jump. So it just make a notch, but all of this is called R. Okay, so if you look at it here, the right bundle branch, if you go to the M, you have letters and T-wave inversion on the V1. And if you go on the left, you have just a little jump. There is no letters, only an R, and it has a T-wave inversion. That's why always follow the M, okay? When you have bundle branch blocks, focus on the M. Okay, and William Marrow will tell you where is the M to go and focus on it. So this is the M, T-wave inversion. This is the M, T-wave inversion. The left one has only R, which is notched, and the right one has different letters. Okay, always describe the M and the M. Don't care for the other one. If you can see here, this one, we go on the M, right? Left bundle branch, go to the M, doesn't cross the baseline. The only one name is called R. T-wave inversion, okay? T-wave inversion. Then we go for here, this is the M on the V1, T-wave inversion, and it changes, so you have different letters, okay? So if it changes side and it has T-wave inversion on V1, it's a right bundle branch block. If it doesn't change side the M and it has T-wave inversion of V6, it's left bundle branch block. So by knowing all of this, let's do again this one. So which bundle branch block is this one? Left or right? Where is the T-wave inversion? Does it jump from the baseline to the other side?
Which
Right one, then branch block.
Yeah, so you have T-wave inversion here, and you know William Marrow. So M on V1, Marrow, so it's right bundle branch block. That's my T-wave inversion, that's my M. It changes from the baseline, this is my baseline. It changes, so it's RQR, yes? So you say this is the M, so it's right. Okay, good. And if you see the axis estimation, it's like it's normal axis, okay? Good. What about this one? It's a bit difficult because there is no notch, but this should be the left one, okay? So you have the M here, the negative T is there. Look for the negative T's. Okay, there are some other types. You can read for them by yourself. What does ST segment represent? And do you know the criteria for ST elevation?
It should be like half of the R wave.
So ST is this one, ST interval, end of QRS, beginning of end of T, okay? On the limb leads, it's 1 small square, on the chest it's 2 small squares, and German uses the same volts, so the same limits, only the width changes. If it's too high, you call it tombstoning. I don't know if you heard this before. So we find the baseline after the T, and then we compare the ST segment. So this is depression, we find it here, this is elevation, okay? Elevation and depression. Do you know about the reciprocals? What is the reciprocal leads? You say like mirror leads?
In the posterior MI, we would see it inverse in the V1, V2.
Yeah, so if you have an ST elevation, then you have a ST depression. Okay, good. So this is theory for the acute. This one is V7, V8, V9. Do you know where they come from? Where do you put them? On the back, good. This is your 12 lead ECG. The way I remember it is that I'm Greek, so I have a Greek pi, okay, the pi, and you know that these are the posterior, right? So V7, V8, V9 are the posterior because they go posterior, so everything else should be anterior, and then you continue like a snake, like an inverted P, so this is the inferior, and everything else is lateral. Okay, find your way to memorize it, that's how I memorized it, that's how I remember it. And you see the reciprocals, like anterior is posterior reciprocal. So you have anterior, the reciprocals are the posterior. So you have ST elevation, ST elevation, ST elevation, ST elevation. Here you have ST depression, ST depression, ST depressions. Okay? So the reciprocals of anterior and posterior, and inferior and lateral. Okay? So if you see on the green ones ST depressions, you should look for these ones. So ST elevations, then here would be ST depressions, right? Okay, you understand? Always, if you see ST elevations, try to find ST depressions, and if they check out, it means you know exactly where the problem is. So electricity will tell you which wall it is, okay? So they will tell you which wall it is. And then from the wall, you can estimate which artery it's supplying this wall. So you know that this is the inferior wall. If you see the inferior leads, inferior wall problem, right circumflex artery, okay? Or if you have a lateral wall, then that's the left circumflex coronary artery, okay? So electricity will tell you the wall, and from the wall you can guess which artery is the problem. That's your STEMIs. That's the posterior leads. Remember, when you change the leads, how do you do it? You don't have extra leads. You just take like V1, V2, V3, or V4, 5, 6, and you put them on the back. So the machine will print still the same number, so make sure to rename it. Okay, so you rename the ECGs. So how do you do it? You just steal the normal leads and you put them on the back, but the machine doesn't know about this, so please remember to rename the printout, okay? Or here, like, everything is changed. What is this one? Where are the ST elevations? Where do you see?
2 and 3.
2, 3, and
AVA.
AVF, which means, okay, and I'm looking next for, I finished with ST elevations, I'm looking for ST depressions, where?
AVR.
So inferior is opposite with the lateral. So lateral is 1, AVL,
V6, V5.
V5, V6. So ST, ST, ST elevations, and then depression, 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 depression. So it looks like it. So inferior wall, and we know inferior wall is right coronary artery. What is this one? Where are my ST elevations?
V2.
Three AVR.
AVR has ST depression.
So basically, ST elevations are not so clear, but you see ST depressions. So you see ST depressions on V2, V3, V4, and you don't see ST elevations. So you don't know which wall. You have to confirm, like STEMI, it's STE, STEMI, elevation. So which wall is elevated, you cannot see here. So what is the next step? If you see depressions V2, V3, V4,
We think about the reciprocals.
yes, so where should it be the ST elevation then? If V2, V3, V4, posterior, so what are you doing now?
We plug them on the
Exactly, on the back side. So then you do the backwards, and there is your ST elevations. Okay, so if you see ST depressions, it must be ST elevation somewhere else. If you see ST elevations, it must be ST depression somewhere else, okay? Reciprocals, mirror leads.
What about suspected ischemia? Do we see ST depressions now?
Suspected ischemia, what do you mean?
Like ischemia of the myocardium.
So unstable angina.
Yeah, I guess.
Okay.
In that case, we don't see
That will
ST.
be non-STEMI changes. So you have
Yeah.
pathological changes, but non-STEMI changes.
So we
I'm
would
trying to
still-
teach the STEMIs and depressions here.
So we
Okay?
still do the thing, but we
You
don't
have you have to do it by law, by legally do it. MIs, what does MI mean? Which means that the membrane is destroyed, which means that the blood has positive enzymes.
Yeah.
And then you go to the green one, ECG. STEMI or non-STEMI? Okay, so unstable angina, do you have enzymes in the blood? No, because it was not infarct, okay? So you said that it's ischemia, so it's not infarct due to ischemia, so it's not MI, so it's unstable angina. And then you have to do the ECG, but you don't need the ECG for unstable angina. What you need it for is positive enzymes, but you don't know which of the two it is. Is it non-STEMI or STEMI? Because both of them have enzymes in the blood. So that's why ECG is important, to see if it's STEMI or non-STEMI. Okay, we did the posterior wall as well. This one. And what is this one? This one. Which wall is affected?
The inferior.
ST elevations in V1, V2, V3, V4, V5, 1, 2. So which wall is affected? Inferior and anterior and lateral, yes. So this patient looks like, how will she look like if all the walls of the heart are dead?
Pretty dead. Pale.
Pretty dead, okay. So the patient is basically a 17-year-old male, 1 week after doing the COVID vaccine, second dose, and then he had central fluid chest pain. It's worse on lying down, better on sitting up. And like I'm helping you here, there's some saddle ST, the saddling, yeah? Do you know spodic sign? Okay, it's a check exam thing, like you need it for a check exam. It's basically going down, like until from the QRS to the QRS, it's like going a bit down, down sloping. And you can see the down sloping here, down sloping there. So, what is this one then? Do you still suspect inferior and anterior and lateral STEMI? Do you still suspect that actually your diagnosis is STEMI in all these walls after giving you the information of the symptoms? So what is it?
You're right.
Acute pericarditis is basically diffuse ST elevations. All of them are ST elevated, but then the symptoms are like not dying. So he's not having a complete heart MI. It's just, yeah, look like this. And there's also some other signs. You're gonna learn them for your internal medicine exam. Yeah, so in the QT interval, basically the men have different than women, okay? And if it's longer than this, then it's pathology. And we're scared because if it's too long, it will make torsade de bonds. So that's like fibrillation kind of thing. And the machine is going to calculate the QT-C for you because QT changes with heart rate. So to standardize it, we just have to say, convert it into as if the patient is 60 BPM. Okay, this is called QT corrected. Okay, so forget about QT, think only about QT corrected. That's what we care about. Okay, and for me, like if it's about 400, then I calculate it myself. There is a calculation you can do. But if it's like less than 400, it's like 370, 380, then you say, okay, I just trust the machine and keep going. Okay, so yeah. And then the last one is that you should go by yourself and find out the ions, digoxin, you know. So we don't have time for this. And that's it, that's the lecture. Hope you liked it. If you have any questions, find my social media and
Yeah.
Thank you.
Thank you.
Thank
no
you.
worries.